This message is brought to you by DoNotAge.org, the longevity research organisation that's on a mission to extend health span for as many people as possible via products that actually work. Start your journey today at DoNotAge.org and use code LLAMA for a 10% discount. That's LLAMA.
I love skiing, right? I love going to the French Alps and skiing. I honestly see no reason why I can't be doing that at 95, and that's one of my goals. And 95, I've just plucked that out because people, don't associate that with people skiing. But I would very much like to get to that age. I'd like to live far past 100 if I can, as long as I could do it in good health. And I absolutely believe that that's possible.
Hello and welcome to the Live Long and Master Aging podcast. I'm Peter Bowes and this is where we explore the science and stories behind human longevity. Today I'm joined by Dr. Rangan Chatterjee, a British doctor and vocal campaigner for a major overhaul of the way medicine is practiced. As he puts it, patients don't need a pill, they need a lifestyle prescription. For British TV viewers, Dr. Chatterjee is The Doctor in the House, the BBC series that helps people overcome their health problems by inviting a doctor into their home to observe their daily lifestyles. Well, the doctor is in the house. Welcome to the Live Long and Master Aging podcast.
Peter, thanks for having me on.
A lifestyle prescription. What does that mean?
I think that's a really good question, actually, because I think we know that actually our lifestyles impact the way that we feel and our risk of disease. But what I don't think is quite as commonly known is the fact that the way we collectively live our modern lifestyles is having a negative impact on our health. And I think many people are doing things day in, day out that they haven't really associated with how they feel. Look, I get it, type 2 diabetes and obesity, we sort of know we need to eat better, we need to move a bit more, right? That's kind of been sort of plugged out for the last few years, well, for many years now. But what I managed to show on Doctor in the House is that no matter what your condition, no matter whether you've already got a disease, no matter whether you want to prevent getting a disease, or if you just want to feel better than you currently do, there's many things that you can do in your lifestyle that's going to help.
Where did you learn to become a doctor, and what got you interested to start with? Was this something that as a kid you felt you wanted to do?
Yeah, it's a good question. I grew up in a family of doctors. So my father was a consultant at Manchester Royal Infirmary. He, like many doctors, came over from the Indian subcontinent in the 1960s when the British government were recruiting doctors. And I was very much surrounded by it growing up. So in many ways, it was a natural extension of just what you consider normal when your father and all the friends and family that you're surrounded by are doctors. It's something that, really comes into sharp focus. I've always liked caring for people. I think that was quite clear to me from a young age. And I went to study medical school at Edinburgh University, and I worked there for a few years afterwards. But I came back to the Northwest, which is where I now live, near Manchester in the UK, to help care for my father, actually, who got unwell. So he had to retire. He had lupus and he was on kidney dialysis for 15 years. And so that whole experience of caring for my father also, I think, has really played into how I practice as a doctor and what I think is important.
And how significantly have your views changed about what it takes to be a doctor from those early days at medical school?
Yeah, Peter, if I'm honest, I look back now, and just to be clear, I've been practicing as a medical doctor for 16 and a half years now. So seen tens of thousands of patients during that time. And I look back to the early years, and I'm not entirely sure that I quite got it, right? You come out of medical school, you've got all these ideals, you think you're being taught how to cure people and get them better. I think somewhere along the way, I realized, particularly in general practice, I really felt that I was helping maybe 20% of the patients that were walking through my door. I could give them pills, but they felt very much like a sticking plaster. I felt like I was very good at suppressing symptoms but not getting to the root cause of problems. And the reason why I think that is because our medical training is very, very good for acute problems. So, for example, heart attack, surgery, even something like a pneumonia, like a severe chest infection. We identify the problem, which is, a bug. We give an antibiotic, we kill the bug, and that problem has gone away. That's fine for acute disease, but the problem is what we're now seeing is chronic disease, and the bulk of chronic disease is in some way driven by our lifestyles and our environment. And I don't think our medical training has changed to account for that. And that really wasn't obvious to me in the early days of my career, but it's become very, very obvious in the last few years.
And so your medical training, and I've heard this from many other doctors as well, the medical training was simply focused on fixing the problem once the problem occurs.
Absolutely. And we're very good at that. And I think that was what I call very good 20th century medicine, but we're in the 21st century now. We know more, we've got more science, we've got more information. We recognize that many of these chronic diseases are multifactorial. So it's not just one problem. There are multiple things going wrong in the body in differing amounts, and you need a multi-pronged strategy to help it. But we're very much taught, what's the problem? Is it this? Is it A or is it B? Well, maybe it's A and B, and you have to tackle them both. And really, it's one of the reasons why, yes, on Doctor in the House, on BBC One, I managed to showcase that actually whether it's type 2 diabetes, which I helped a lady reverse in 30 days on television, but what makes me happier, Peter, is that lady, I have not seen her in over 2 years.
I was just going to say, how is she doing now?
She still does not have diabetes.
Good.
Her blood sugar is better than when I left her house. And what's important about that is this is a lady whose life has been transformed. She is empowered with the right information. This goes far beyond just, eat less and move more. This is specific information for her. But for 2 years now, she's not had to go and see her NHS GP. She's not had to, she's not had to cost the NHS any money at all.
And just for people listening outside of the UK, this is the National Health Service that you're
Absolutely.
talking, who you work for.
Yeah, the National Health Service is, it's the healthcare system in the UK. Everybody has free access to that, but, it's crumbling. It's really, there's a lot of pressure on it, and we're struggling to cope. The reason we're struggling to cope is because there is too much lifestyle disease being put on the NHS, and its system is not set up around that. So this is an isolated case of somebody who had type 2 diabetes, a condition that's costing the UK in direct and indirect costs £20 billion a year. And this is a condition that's largely driven by our lifestyles and our environment. This is a lady who reversed it, and 2 years on, without any more input from me or anybody else, she's kept it off, right?
And for those of us who haven't seen that episode of the show, what did you do in those really few days, few weeks that you were with her? What did you do to so dramatically change her life?
Yeah, so I explained to her what she needed to do for her condition. Right, let me just back up a little bit. Many doctors and many people in the medical profession say, patients know what to do, but they don't listen to us. I don't buy it. And the reason I don't buy it is because there's a difference here. Let's say you have a 10-minute consultation with your patient, and let's say the patient comes in, they've got type 2 diabetes. Scenario one is, Mrs. X, you've got type 2 diabetes. We've got multiple medications. You're going to need those medications. We'll start you off on this one. In a couple of years, we normally need to add it up. It can give you all these complications. And as they're walking out the door, if you can actually lose a bit of weight as well, that's really going to help. Contrast that with...
So it's a sort of, and by the way.
And by the way, whereas you contrast that with someone who walks in and you say, hey, Mrs. X, you've got type 2 diabetes. Now, look, this is very much a lifestyle condition. We've got some drugs, but I think there's a lot we can do without using those drugs. Let me show you. Are you interested? They're all interested. And the phrasing and the priority we give to it is key. If we're not trained in these lifestyle interventions, we are never going to prioritize them. They're going to be a footnote at the end of a consultation. So with this lady, she was eating too many refined and processed carbohydrates. So her bread was white bread full of sugar as one of the ingredients, biscuits, cakes, muffins. But even for her, things like white rice, which for some people can be very healthy. But for her, her condition meant that she no longer tolerated refined carbohydrates very well. Nobody had told her this before, so I just removed those, encouraged her to eat whole, real food. That was the first part of the strategy. I also had to tackle her sleep and her movement and her stress patterns. But just by doing that, we're talking about a chronic disease that is meant to be irreversible, 30 days later, she was no longer in the type 2 diabetes category. She'd gone through the pre-diabetes category and she was in normal ranges. Right? I wasn't expecting it to be that profound. I was delighted for her, but more delighted that she's kept it off 2 years on. So if we translate that across the whole country, the savings are, staggering.
And if you extrapolate that to other conditions that could be improved or even eradicated or prevented through similar techniques, heart disease, even some cancers, the amount of money that could be saved is astronomical.
Absolutely. So, look, even the World Health Organization on their website will say that chronic disease, 80% of it is driven by our lifestyles and can be impacted by our lifestyles. And they even say that cancer, 40% can be impacted by our lifestyles. So if that's the case, surely doctors, who are the first port of call for many of these patients, should at least have a bit more detailed information about that. And sometimes when I talk about this in public, people say, yeah, but they could just refer them on. As a general practitioner, if I refer someone with a nerve problem to a neurologist, I've still been trained in neurology. I still know what they're going to do. I'm just referring them for extra expertise. We need to understand the power of nutrition and lifestyle. Yes, we can refer on then to a nutrition professional to go into the actual nitty-gritty of it, but often you can actually do a lot in 10 minutes. And I do this in the NHS, and you can have an impact.
But that is one of the issues, isn't it? The 10 minutes. The 10 minutes that on average, let's say you tend to get to spend with a patient. And for some, I agree, you can probably say a lot in 10 minutes, but for others it will take much longer than that.
Absolutely. So look, here's the thing for me. I think that the age of the 10-minute consultation is dead, or it should be dead. Okay, I think it's simply very, very hard for the complexity of problems and the multifaceted nature of problems that we're seeing today. Really, in 10 minutes, it lends itself to a pill fix, right? It does. And I know what that scenario is like. I know the pressures for that. But if that's not the best thing for the patient, we have to fundamentally ask the question, is the NHS set up right? Is it still set up in the right way for the problems that we're seeing today in 2018? Okay, this system may have worked in 1980 and 1990. It's not really working very well today.
And you're here in Los Angeles at the moment. And as you look, and I'm sure you observe from a distance how the American health service works, the health system here, which clearly has its problems and it has its political issues. Do you see any lessons that could be learned from the way that things are done here?
Yeah, I mean, I've got a lot of friends who are medical doctors here in the United States, and I think a lot of the problems are very, very similar. I think the way healthcare is set up is very different. I think as you know, in the UK, we all have that free, or what we consider to be free healthcare. We are paying for it through our taxes, but it's free healthcare. Whereas I think here they're used to paying for their healthcare, and I think that poses quite an interesting dilemma for me, in the sense that if we say we're moving into an era of lifestyle-driven illness, if you're not paying for it, there's no real financial incentive on you to make those changes. Now, that's a little bit politically challenging to say, and I must say I'm very proud of the NHS, and I think it should be free for everyone, and I think that's something we can be incredibly proud of in the UK. Do
you mean, in a sense, that if you're not paying for it, you tend to take it for granted, and it's kind of easy come, easy go sort of thing, you don't have to listen, whereas if you're paying for something, well, you better listen because you want your money's worth?
Yeah, absolutely. I think there is absolutely something in that, and I don't know the solution for the NHS around that, but I think many people do take the NHS for granted. I've seen that in many of the practices I've worked in, and I'm not putting blame on people, right? I get it. We've been conditioned to think that disease may be a result of our genetics. We've been conditioned that there is a pill for every ill, and we've been conditioned that we go to the doctor and we get a prescription. So I don't think it's necessarily the public or the patient's fault that, they do rely on the NHS and they do take it for granted. Many people do. But I think we need a radical overhaul of how we do this, because I honestly can't see the NHS being sustainable for that much longer if we keep the current system. And I think we need to be a bit more adventurous and think outside the box as could we could we do things in a different way? So, for example, in America, there's a growing movement of health coaches. And so these people who help people make behavioral change.
And these are not doctors, generally.
These are not doctors. But I'm a huge fan of that because I think, well, maybe we need to incorporate health coaches into the NHS. So, maybe a lot of this lifestyle training gets done almost before you see the doctor for these chronic conditions. I don't have the solution, okay? But I think we do need to think about things in a different way. And I don't think the argument is good enough that we only have 10 minutes, so we can't go through lifestyle. If lifestyle is the treatment, we've got to find a way to make that work.
Let's talk a bit more about your sort of fundamental ideas and your passion for this. And I know you have a deeply personal story involving your son that really focused your mind and I think changed a lot of your ideas. And we'll continue this conversation in just a moment.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
Yeah, so I think before this happened with my son, I'll go into that in just a second. I think looking back, I'd always had this slight disconnect with the medicine that I was being taught and what felt intuitively right to me. So I remember actually in the first week of qualifying as a GP. So just to put it in perspective, I started off as a specialist. I got my exams there. I became a member of the Royal College of Physicians. I was going to be a renal doctor, a kidney specialist. And I felt that medicine was becoming quite separate. And we were seeing the different organ parts as, completely different systems. And we weren't really integrating things together. And I was getting a bit frustrated. I didn't want to spend my whole career just looking at kidneys. So I took the rather unusual step of moving from specialism into generalism because I wanted to see everything. And I remember my first week as a GP, I remember somebody came in and there was a young lady who had mood problems and, she'd been diagnosed with depression. And I won't go into everything about the story, but, I had a letter advising me to start an antidepressant on her. And something intuitively just felt wrong. I can't just put this young lady on a pill. I need to understand what's going on here. I had 4 or 5 people waiting outside. It was a busy afternoon surgery. So I remember chatting to her, and she was in with her mother, actually, who was very concerned about her. And I thought, you know what, there's more to this than meets the eye. So I said, look, let's have a chat. I ended up spending 20, 25 minutes with her, and there was more people waiting at the end. And I said, look, can you come back tomorrow morning at the end of my morning surgery? I'd love to speak to you a bit more and just try and understand what was happening. And basically, by doing that, I would then see her for a 10-minute appointment every week. And I started to develop a relationship with her. I started to understand what was going on in her lifestyle that was driving her to feel that the way that she felt. Within 2 months, we got her feeling back to normal. And 6 months later, she came in for something else. She says, I feel great. And this is a lady who could have been labelled, who could have been put on a pill, potentially for life. And actually what she needed was somebody to understand what was going on in her life. Now, look, Peter, what are we going to say? We're going to say that actually it's not realistic to do it in 10 minutes. So what we'll do then is we'll label her, this individual, we'll put her on a medication for the rest of her life. Or do we need to say, actually, something's broken here. We need to look at the system in a different way to see if we can actually help everyone in that way. And I did that in the National Health Service. So yeah, people will say, oh, doctor in the house, you get more time. I get that. But that was within the constraints of the health service.
So you have to be prepared to use that phrase, think out of the box, to not to follow the A to Z of what you, as a doctor, you would normally do.
Yeah, and that brings up another point, actually, which is, as doctors, we're meant to sort of follow something called evidence-based medicine. Now, the the forefather of evidence-based medicine, Professor David Sackett, in the British Medical Journal in 1997, there's a beautiful article by him, and there's this diagram there which tells us what evidence-based medicine should be. And it's the intersection of three things. The research evidence is one thing. Patient preference is the second thing. And clinical expertise is the third thing. We have really hijacked it in our heads to be research evidence. Okay? But if medicine is just about research evidence, then actually we can follow protocols. You don't really need a doctor. We can just follow a flow chart. There's something more to it. There's a skill in being a healthcare professional. And, really we need to get back to evidence-based medicine, how do those three things interplay? So with that lady with depression, maybe the flow chart was telling me to put her on an antidepressant, but it didn't feel right. My clinical expertise, my experience taught me it actually doesn't feel right here. And then you talk to the patient about what they want, the patient preference. And that's how I believe you get people better. And that's what's hard to do within 10 minutes.
And there's a lot of talk about functional medicine these days, whole body medicine, which is essentially what you're talking about.
Yeah, it very much is. And so, look, I think all these terms, they, whether it's in diet or whether it's in the type of medicine you practice, when we start putting these labels on it, it starts to get quite divisive out there in the social media world. People fight over what is this, what's right, what's wrong. And we need to take a step back. And
no, it's all healthcare, isn't it?
It's healthcare, and it's good quality healthcare. So I think I prefer to label this kind of medicine progressive medicine. I think it's medicine for the 21st century. It's recognizing what we're so good at as modern Western medical doctors, in the way we treat acute disease, but recognizing also that we're probably not so good with chronic disease, and going, hey, that's okay. We're good at this, but let's upskill here. Let's expand our toolbox. And that's what I do. I think I practice good medicine. I try and practice and use safe interventions first. If those safe interventions, those harmless interventions aren't working, then I start to go to more harmful interventions like certain medications with side effects. But if I know lifestyle can help, why would I not use that? And Peter, I think it's really important to get the point across that I think intuitively people know type 2 diabetes and obesity are driven by lifestyle. But I've shown on Doctor in the House, and I do this with my patients, that fibromyalgia, chronic fatigue syndrome, there's multiple components there, but changing their lifestyle, and it can be hard for them because they feel knackered all the time, actually that can start to get them feeling better. Even thyroid complaints. I had a lady on who came on to me on BBC Breakfast recently to explain that when I first saw her in the NHS about 4 years ago, she was on 75 micrograms of a thyroid medication per day. And her doctor had told her that there's nothing she can do with her lifestyle. That's the condition. That's what she has to take. And she said, yeah, doctor, but I feel dreadful. I'm still feeling exhausted. They go, well, look, that's just the condition. You're going to have to take this medication. Your blood tests look absolutely fine when you're on that medication. She came to see me. And I thought, well, if that's the condition and that's the treatment, yet she still feels exhausted and she can't function, actually, as a doctor, there's something missing here, right? I don't really care what the blood test tells me. At that point, it's like, well, how do I get her better? And by really delving into the fact that a thyroid condition is an immune condition, so it's an autoimmune condition, right? But we also know that the foods that we eat impact our immune system. So I specifically taught her what foods might be putting strain on her immune system. Why not, would she be interested in having a trial without those foods? And really, by doing that, she got her energy back. By doing that, within 2 years, instead of being on 75 micrograms of thyroxine per day, she was on 25 micrograms of thyroxine per day. Now look, we're not reverse the condition, but she's having less medication. She feels better. She's still got the thyroid complaints, but it's just much better. It's saving the NHS money. And more importantly for me, she's feeling better. She's functioning better as a mother. She's functioning better as a wife, and
for all some pills, maybe a lot of pills are safe. I think most people will recognise that the fewer that you're actually putting inside your body, the better.
Absolutely. There's no question about that. There's another lady, again, she was on BBC Breakfast recently with me because I was on doing a feature because I've just created the very first Royal College of GP prescribing lifestyle medicine course. So it's the first time that doctors now can get CPD accreditation points for learning how to do this. And her story was that she had got 6 or 7 diagnoses: fibromyalgia, underactive thyroid, anxiety, irritable bowel syndrome, and the list went on. And each year she was picking up more and more medications, but she was still feeling dreadful. And I went and saw her, and she was on 20 different medications. Now, if those medications were helping her and she was feeling good, I'd understand it. But if you're on 20 medications and you still feel rubbish, you've got to take a step back as a doctor and ask the question, are we really helping her? Again, over the course of 6 weeks, we were managing, I helped her get down from 20 medications to 2 medications. So that's a reduction of 18. And her pains had gone. Right, so why can't every patient in the country have access to that kind of healthcare? That's my goal. And one of the ways I hope to achieve that goal is by starting to train doctors that there may be more tools that we need to have in our toolkit.
I know you have a 4-pillar plan, and I want to get to that in a second, but I asked you about your son because I've read about the story. It's quite a heart-wrenching story in many respects and must have been very frightening for you. Just run us through what happened and how it affected you.
Yeah, so what happened is my son, who's now 7 years old, when he was 6 months old, he had been breastfed by my wife for the first 6 months as per the recommended guidance. We're a pretty health conscious family, and we were on holiday in France, and basically he had a convulsion. He stopped moving suddenly. I can remember it so clearly. We were staying at a friend's chalet in France, and my wife called out to me because his arms went back and he just stopped moving. I thought he had had a cold that day and he was a bit mucousy, so I thought maybe he's just choking on some phlegm. And obviously I was panicked, I was scared, I turned him over, I tried to clear his airway, and I froze, right? At that point, I wasn't a doctor really, I was just a worried father. And it was my wife actually said, come on, we've actually got to get to hospital now. And we got to the A&E there in France, and convulsions are actually quite common in kids, or they're not uncommon, but they're associated with temperatures. It's called a febrile convulsion, and they're not particularly worrying. What was worrying is that he had this convulsion and he had no fever. And you could see that the whole medical team were worried. It's like, there's no fever. What's causing this? He had to get red lighted down. We were in a mountain town, down the valley to the main hospital. He had 2 lumbar punctures that night. We thought we were going to lose him. It was incredibly scary. And what transpired is that he actually had a vitamin deficiency. He had no calcium in his body, well, very little calcium. His calcium level was barely compatible with functioning, which is why he had a convulsion, but that was secondary to a low level of vitamin D. So he had a vitamin D deficiency, which caused a low level of calcium. And modern medicine quickly fixed him, right? We gave him a calcium infusion, and he got all the vitamin D that he needed. But the problem is that vitamin D is involved with your immune system and your immune system development. So I was starting to think, well, how long has this been going on for? Has that impacted the way his immune system has developed? Is that why his skin is really bad and he's got bad eczema, etc., etc.? And really, I couldn't get my head around the fact that I had been a practicing doctor for many years. I got all my specialist exams. I got my general practice exams. I'm a health conscious individual. And my son nearly died from a preventable vitamin deficiency. And if I'm honest, Peter, there's been a lot of guilt associated with that. I was determined to get my son back as if this had never happened. It was almost like a vow I made to myself. I would study every day. I'd read about this vitamin. And, in the age of the internet, you can access everything. So I'd read about 3 hours a day on vitamin D. And then as I read about it, I'd learn more and more science, up-to-date science, very relevant science that I thought, I've not learned about this. I've not been taught about this. This is how I can help so many of my patients. So really the principles I learned, I helped my son and he's thriving, he's incredibly well, his skin's perfect, he's just doing great. I started applying that with myself, with my wife, with my sort of immediate family. We all started feeling better. And now I apply it with my patients, and I've got to tell you, I'm never prescribing as little medication as I am now. I'm not anti-drugs. I prescribe medication when it's necessary. But I'm just finding that for a lot of the conditions I used to prescribe medication, I don't need to anymore.
All based on really simply improving your own education, that aspect of your training that really never existed. And I suppose accepting that things change and science develops and new ideas come and go. Some stick if they work and others don't. But you've got to keep educating yourself.
You've got to keep educating. And you know what, Peter? The thing is that we can be quite slow as a profession to change, and we can demand quite a lot of research and evidence first. And I get that and I understand that, but we have got a chronic healthcare crisis that is putting healthcare systems around the world under huge strain. We cannot wait 30 years for the trials to be done in the same way as they're done for harmful drugs. And we've got to take a pragmatic approach and go, well, that science is pretty encouraging. It's a safe intervention. Why don't we try that? And
you just kind of hit the nail on the head of what I often say about scientific trials. And I've talked about this a lot. I've taken part in a trial for looking at fasting mimicking diet and the positive impact of certain fasting regimes.
Voltalongo.
With Voltalongo, yes, at USC. And it's something that I've continued beyond the trial because I wanted to see how this worked long term. It isn't to the nth degree proven science, and it may not be for a century because longevity science takes a long time to figure out and to see what's working. But as you say, it's not harming me. It's not, and the many others that do this, it's not dangerous, and that's fairly obvious. And the benefits, the potential benefits, are so good. Why not do it? Why not try it?
Yeah, exactly. And I think this whole need for evidence. Look, if you're going to put someone on a chemotherapy drug, right, that has got some very harmful side effects, you know what? We need a lot of evidence that is going to give you some benefit before we put that sort of risk on someone. Absolutely. But what, fasting? I mean, we've got to take a pragmatic approach. And you know what? Be honest with our patients and tell them, this is where we're at. What do you think? Would you like to try it? And that really reminds me of something that I talk about a lot when I'm lecturing these days, which is, social media can be quite divisive now. People get into their tribes on what the right way of eating is and what the one right diet is, and I sort of cover this a little bit in my book. I talk about...
And this is the 4 pillars of health.
It's called the 4-pillar plan.
Yeah.
And it's basically on the 4 key areas that I think we've got control over in our lifestyles that can significantly impact our health, which is food and movement, which I think we know, but also sleep and relaxation. But, let's take something like type 2 diabetes. We've got Professor Roy Taylor at Newcastle University reversing it on a 600-calorie liquid diet. Okay, we've got many patients who go on a what they call a low carbohydrate diet, reversing type 2 diabetes. But then you've also got some people in the plant-based sort of vegan community who actually manage to reverse their diabetes on a low-fat vegetarian diet. Right. So here's the thing: instead of fighting over who's right, maybe we need to recognise that actually, for different people, these differing approaches are seeming to work, right? So maybe as doctors, we should be saying, look, there's these approaches that are out there. What do you think? What fits with you, with your belief system? What fits with your lifestyle? What would you like to try, if any of them? And I find that a much more exciting way to go forward with what I call progressive medicine. It's just trying to present options, really empower patients and let them be part of it. So it can be a partnership. I think that age of that didactic relationship where patient comes to doctor tells patient what's wrong and what to do, I think that age is coming to a close pretty soon, actually, and it needs to be much more participatory, much more of a partnership.
And of course, tech is allowing us to do that. The way that we can share data, and big data especially, and people at their home, at work, they can, almost without thinking about it, wearing gadgets, wearing tracking devices, contribute to that collection of data, that we're all part of this now in a much more significant way than we used to be.
Yeah, and that will ultimately end up being a big part of the research, right? It's a new way of doing research, a new way of collecting data. It's not the same as a randomized controlled trial, but actually it has value. It has incredible value. So yeah, I absolutely think the way we've looked at health, the way we have looked for answers before, I think with technology, it is changing everything.
Tell us a bit more about the 4-pillar plan. This is your new book that's coming out this month.
Yeah, the 4-pillar plan basically it's really about giving people practical tools and practical suggestions that they can utilize in their own life. So the key premise is that in 16 years of seeing patients, and tens of thousands of patients during that time, I've realized that actually the tools that I now use with my patients who come to see me are the same tools that pretty much everyone can apply to improve their health. So this is applicable to people who have a disease, people who are trying to prevent getting a disease in the future, or people who simply just want to feel a bit better than they currently do. They want a bit more energy. They don't want to have brain fog in the morning. They just want to be able to function better. Because I believe we all pretty much these days have the ability to feel better than we currently do. I think one of the big problems is collectively the way our modern lifestyles are set up. And this is not about blame. It's not about telling people that, their lifestyles are off. This is about helping educate people about what is going on in our current lifestyles and how that may be impacting our health. So the book is split up into 4 parts, 4 pillars, and it's literally 25% of the book is on each pillar. So I was very keen to not only say that all these pillars are of equal importance, I was keen to demonstrate that by actually literally having 25% on each, because a lot of books will talk about food, and a lot of these books I love, right? And they'll sort of pay lip service to movement and sleep and say these things are also important. But I really want to get the message across that actually these are all critical components, and you don't have to be perfect in one pillar, but you have to pay attention to all 4.
And you don't necessarily distinguish between those people who choose to eat meat, those who are vegan or vegetarian. It's well known, I've talked about it a lot, that my regime of choice is a plant-based diet with a little bit of fish occasionally. But we can all suffer from overexposure to mobile phones, too much technology, too much light in the evening. There are issues that are common to all of us, no matter how we choose to eat or exercise.
Yeah, absolutely. This book is designed to be applicable to everybody, okay? I don't want to marginalize a group that says, actually, this book isn't for you. No, even my food interventions, my suggestions around food are applicable to whether you want to eat meat or whether you want to be vegetarian. They're broad enough where everybody can apply them. Because I think we fight about the 10% difference in everyone's diets. 80% of what differing food movements talk about is the same.
That's crucially important, because there is no one way to do it. There's no one single right way to live this, as we talk about it a lot in this podcast, a long and healthy life. We want to optimize our chances of getting to a ripe old age, but we're all very different. We're all made in different ways.
We're very different. We've all got different cultural beliefs. We've all got different preferences. We've all got different jobs. We've all got different lifestyles. So how can one prescription for everybody? It can't. And I felt really passionately about writing a book that actually is inclusive to everyone and has some common sense, science-based and clinically based interventions that can help everybody. And I know this works because not only do I do it myself, not only do my family apply the principles in this book, these are the same principles that every single day in my practice I'm talking to my patients about, and I am seeing the feedback, I'm seeing the results. So this is born out of 16 years of experience. It's born out a lot of recent science, but I'm not blinded by the science in this book. I use science, I quote the relevant studies, but I also accept that sometimes there is not a research trial to support what I'm saying. But I'm open and I say, hey, look, this is what I've seen in 16 years of seeing patients, but I can't find you the right study for this because the study doesn't exist. And I think we've lost a bit of common sense in medicine and in health. And I think we need to actually have that dose of common sense back. And I'm hoping that my book provides that.
And what aspect of what you've learned, and obviously there's a lot, but if you could maybe pinpoint one or two things that you apply to yourself, and you can really say, look, I've changed. I'm an example here of perhaps I did something in one way 5 years ago, but I've come to learn that perhaps I should be doing it like this, as it maybe applies to your diet or your exercise regime, or how many hours sleep you get, or how you manage stress.
Yeah, there's probably two key things that come to mind straight away. The more recent one is sleep. 2 or 3 years back, as I was delving more and more into the research on sleep, and I saw what happens to the body when we sleep and how critical it is, and how really, as a species, we've almost become a little bit overly arrogant to feel that we can actually, we can basically go without sleep. I've started to prioritize it. So I will, as a routine, I will make sure probably by 8:30 p.m., that's what tends to work for me, I will switch off my mind from my sort of emails and my phone and my devices. So by and large, and I'm not perfect, I'm as guilty as anyone of being tempted by the things, but I try roughly at about 8:30, I try and switch my phone off, switch my computer off, and I'll unwind. And normally by 9:30 or 10, I'm in bed. Normally. And that is very different from 5 years back, when I'd often be up at midnight or 10:30 and I'd be doing things. And I feel like...
Did you find you were doing things but not particularly productively?
Absolutely. And then, you'd be fighting that fatigue the next day. You'd be craving more sugary foods. And it's all downstream,
it's a vicious circle,
from the fact that you didn't sleep. And I find now, and it's hard to say, but arguably I think sleep is probably one of the most undervalued pillars of health, because if we sleep better, I actually think it's easier to do the rest of the lifestyle changes. I think it's much easier. And actually I think we can tolerate not being so good with the other lifestyle changes like food or movement if we have slept well. So for me, changing my sleep pattern has been significant, and it's become quite addictive. I don't find it hard, because...
I was going to ask you about that, because I know some people try to do everything right and have the kind of regime that you talk about and are in bed by 10 o'clock. Some people will say, I actually can't sleep for 8 hours. I wake, and generally older people will say, I wake up at 3, 4 a.m., I'm wide awake and I just cannot get back to sleep. So I haven't had my 8 hours and I might be falling asleep in the afternoon. So the question is, how do you stay asleep?
Look, it is so hard to give a generic answer to that, because there are so many factors that play a role in that. What I would say is that by and large, there are sleeping disorders like sleep apnea, which require a certain treatment. But by and large, the majority of sleep issues are lifestyle related. So what I mean by that is the natural state for a human being is to be able to sleep for an appropriate length of time and deeply. Okay, that's our normal sort of almost birthright. Normally what's happened is that we are doing something in our lifestyle unwittingly that's untraining our natural ability to sleep. That's how I view it. So I'm always looking with my patients, what are you doing that's actually stopping you sleeping? So instead of looking for a sleeping pill to help get you to sleep, I'm saying, what are you doing, or what could be going on that's actually untraining your natural innate ability to sleep? And I find by and large, you can normally find something that when you change it, you then start sleeping deeper. And I try and go through that in detail in the book, and I try and go in that 25% on sleep. I try and sort of tease out what those things might be. Again, it's not prescriptive. It's about trying to say, hey, look, why not try this? Does that work in your lifestyle? If it doesn't, okay, fine, let's try something else. And Peter, was something you said earlier about your own preference is to have more of a plant-based diet. I find that really interesting, because I think everyone has their own preferences. The research that they've read and how they interpret that and what they feel is the right thing to do.
Well, that's why I phrase it like that, because I know it isn't for everyone. But I mean, you actually hit the nail on the head there by saying that you read research, you talk to scientists, and you try things out. And it simply is, for me, it feels like the best way forward.
Yeah. And so therefore, you've already got buy-in, because you believe that. And therefore, I think our job as healthcare professionals and as a doctor is to work around your choices and work around your belief system. Go, okay, how can we optimize that? And, I really do. One of the frustrations for me with all this fighting over the one true diet, and I specifically have a section in the book where I talk about this, and I say there is no one true diet. Okay, that human beings have always been opportunistic omnivores. We have eaten dependent on our geography, dependent on our climate. That's the way it's always been. We can adapt and thrive on a whole variety of different diets. One thing I would say is that what tends to be consistent amongst all healthy diets is that they are generally whole food based, they're minimally processed, and they're not full of highly processed junk food. Whether you want to be vegetarian, you can be vegetarian two ways. You can be vegetarian eating a lot of highly processed junk food and be technically vegetarian, or you can be vegetarian and have lots of whole, healthy, real foods, right? It's completely different. We talk about fats. You can have healthy natural fats. You can have unhealthy damaged processed fats. So that's why I personally, and I've got a lot of friends who talk about fats and carbs, I tend to stay away from that because I don't find it particularly helpful, because I just think it doesn't tell me anything. I'm more about the quality of that person's diet.
And I think it is maybe wise to stay away from it, because it's a whole new debate, especially when we're talking about high-fat, low-fat diets, which are hugely controversial. We went through a whole long time when everything was low-fat and we used margarine instead of butter, and now the pendulum swung and people are adding butter to their coffee. And it's a controversial area. Maybe without getting into the science of it, maybe just address the fact that people can be easily confused, and it's actually deeply unfair, I think, oftentimes.
Yeah,
maybe if you're talking to a patient who's seen something on TV or read something in a magazine and they're just totally bewildered.
Absolutely. And that confusion then leads to inactivity, because they're so confused. I think, well, nobody knows. The experts don't know, so I'm just going to do what I like doing. Okay, and I've heard that so many times. So I do agree that the low-fat movements over the last 20, 30 years has caused there to be a lot of artificially low-fat food. So, like, say, yogurt. You take the fat out, put in sugar to make it taste good. Okay, so that is what I would call an unhealthy low-fat food. But, you can have a healthy salad, let's say, that's low-fat. So it's not that low-fat or high-fat is necessarily the problem. It's what is that made up of? So I'll give you an example, right? How do the Okinawans in Japan, one of these blue zones, so the blue zones are these little communities where they live, they seem to have high rates of longevity. Their diet, according to most reports, is 70-80% carbohydrate based, but it is whole food carbohydrate. It's basically mainly around their sort of purple sweet potatoes. That's very different from, let's say, an 80% carbohydrate diet that you might have in the West, which is full of crackers and rice cakes and highly processed breads and muffins. So when we talk about carbs, I find it, well, what is the quality of that carb? And it can't all be that carbs are bad and fat is good. It's the kind of fat, it's the kind of carbs. And that's something I feel incredibly strongly about. And I really try and tackle this in detail in my book, in the food section, because I think if you focus on the quality, I think for most people, actually, how you break down fat, protein, and carbs doesn't matter so much when you get the quality right.
Quality and quantity.
Quality and quantity. But often, if you're, here's the other thing, Peter, as you've probably found before, is when you focus on quality, so you're putting in quality whole foods, often the quantity takes care of itself.
And sometimes comes down. Because I think you're satisfied by a smaller helping of really good food.
Yeah, absolutely. It doesn't always apply that way, but by and large, I find, you asked me what I do, sleep is one of them. Changing my diet to primarily whole foods is something, again, I probably did about 5 years ago. And I find it very easy now. And because my taste buds have changed, I really don't get tempted anymore. Did I used to get tempted? Yeah. Was it hard at first? Absolutely. Incredibly difficult. But, you do get used to it. Very soon it becomes your new habit. And I find my appetite control is almost effortless now. Because I only eat whole foods, my body knows when it's full and I stop eating.
Let me just ask you one final question. Often asked this question. In terms of your own longevity, your own lifespan, or your own health span, which I think is probably more relevant, is it something you think about a lot? I mean, clearly you think about the broader issues all of the time, but as it applies to you, do you have a vision of the future for yourself?
Yeah, absolutely. I think about this all the time. And with all the research I do, and the more science I read, and the more I think about health and nutrition and longevity, I honestly don't see any reason why I can't be 95 and skiing down a steep mogul field in the Alps. Okay, I know that's a bit out there, but I love skiing, right? I love going to the French Alps and skiing. I honestly see no reason why I can't be doing that at 95, and that's one of my goals. And 95, I've just plucked that out because people don't associate that with people skiing. But I would very much like to get to that age. I'd like to live far past 100 if I can, as long as I could do it in good health. And I absolutely believe that that's possible.
And do you think that is a realistic goal for most people these days? Or are we still, I mean, the average lifespan is still about 80 years old in the Western world.
Yeah, I think a lot of people are not sure they want to live for a long time because I think they associate that with being in a nursing home or living in ill health. But I had the fortune in June of 2017, I hosted a conference in Guernsey with someone called James Maskell.
Well, we've had James on the podcast talking about it, yeah.
Yeah, called Live to 100. And it was incredible. And I had the real great pleasure of the day before the conference, I was introduced to Michel Poulain, who is the Belgian researcher who coined the term blue zones. And I went to visit a 102-year-old chap in Guernsey. I remember clearly I went and I knocked on the door. And I'm used to doing house calls in the UK. And what was really striking is this gentleman came and opened his own front door. So I know that why should that be so abnormal to me? Well, my own experience, and I guess I've got to also recognise that as a GP, I'm called on a house call when someone is sick, right? So clearly, in a lot of those cases, someone's going to need help to answer the door, or they're often in a nursing home. But he just came pretty sprightly. He opened the door. He came, made us drink. We sat down. We had a chat, and he really said his health was great until he was 95. And that's when he started seeing doctors, and then his health started to deteriorate. And I found that really interesting. And we delved in a bit into his lifestyle. And, really, he was active every day because he had an allotment and he would go there to get his food every day. He wasn't joining the gym. He wasn't trying to be active. Activity and movement was just part of his everyday life. He talked about this treat that he would have. There was some special Guernsey sweet bread dish. And I said, how often do you have that? Do you have it most days, once a week? He goes, oh, no. We'd have it maybe at Easter or maybe at Christmas. And it's not about never having sugar or never having a treat. It's that treat was now and again. They would have it at special occasions rather than having it every day. And here's the problem. Sugar now has become the everyday norm rather than the occasional treats. I think that's the problem. I don't think necessarily sugar is something that we should never have. I think humans have always eaten sugar to a certain degree. We weren't having it, though, breakfast, lunch and dinner like we are today.
This has been fascinating. Really interesting to talk to you. The 4-Pillar Plan is out this month in the UK and the rest of the world.
UK and Commonwealth now, and it's coming out in America later on in the year.
Thank you so much.
Thank you, Peter.
Just before we go, a reminder that there are several ways to listen to us via TuneIn, Google Play Music. Our website is lamapodcasts.com. That's LLAMA podcast.com. Listen to us through iTunes. And if you enjoy what we do, a 5-star review at iTunes would be hugely appreciated. It helps us to grow and secure the future of the podcast. Many thanks for listening. Health optimization is what this podcast is all about, and that means taking care of our mitochondria, the energy centres of our cells. Physical strength, avoiding frailty is key, and that's why the science behind urolithin A and the work of Timeline Nutrition is so interesting. You can find out more and get a discount code at our website and in the show notes for this episode.